Now in this video I'm going to discuss a case of chronic liver disease. And my case will be decompensated, so you can say decompensated chronic liver disease. So let's begin our case. Mr. Anisur Rahman, a 55-year-old man from Mymensingh, presented with generalized swelling of the whole body for last 3 months, yellowish coloration of eyes and urine for last 15 days. Generalized swelling first appeared at abdomen, then gradually involved both lower limbs. This was associated with abdominal fullness and heaviness and anorexia, but not associated with abdominal pain, alteration of bowel habit, chest pain, orthopnea, paroxysmal nocturnal dyspnea, persistent cough, or any high-colored urine. For this, he was put on diuretics by a local physician, with which abdominal swelling partially subsided. He also complains of yellowish coloration of eyes and urine for 15 days, associated with marked fatigue and anorexia, which is gradually progressive. This was associated with dark stool, but not associated with generalized pruritus, right upper abdominal pain, fever with chills and rigors. He had no history of any preceding prodromal illness or progressive pallor. With those complaints, he was hospitalized at MMC and was evaluated with ultrasonography of whole abdomen, few investigations of the blood, and ascitic fluid study. Then he was referred to BSMMU for further evaluation and management. After hospital admission at BSMMU, he developed blood mixed vomiting and melena for several episodes. He was resuscitated with blood transfusion, IV fluid, and endoscopic variceal band ligation. During his course of illness, he had no history of seizure, unconsciousness, abnormal behavior, or altered sleep rhythm. There is no history of high fever with abdominal pain. He had no history of previous jaundice, any surgery, unsafe illicit sexual exposure, unscreened blood transfusion, any abnormal movement, or any other autoimmune diseases. But he used to share the shaving razor in the salon. He had no history of previous tuberculosis, contact with smear-positive pulmonary TB patient, or any nodular swelling. He had total 3 hospital admissions, one at MMC, one at an outside hospital, private hospital, and the current admission is BSMMU. He has 3 children. All of them are in good health. No history of such illness in his family. He is an ex-smoker. He smoked 15 pack years. He is non-alcoholic. He is vaccinated against COVID-19, but not vaccinated against hepatitis B virus. This is all about my history. On general examination, the patient is anemic, mildly icteric, JVP is raised, few spider angioma over front of chest, skin is darker than usual, leukonychia involving nails of both hands and toes, bilateral palmar erythema, bipedal pitting edema, and an IV cannula in situ. There is no lymphadenopathy, purpuric spot, or bony tenderness. Bedside urine for protein is negative. There is no flapping tremor. Other general examination findings, including vitals, are within normal limits. On abdominal examination, abdomen is distended, flanks are full. Umbilicus is central with transverse slit. Engorged visible veins are seen and directed away from the umbilicus. There is a puncture mark in right lower abdomen. There is no organomegaly or lymphadenopathy. Ascites is present, evident by shifting dullness. Testes are small, soft, and non-tender. Other systemic examination, including chest and precordium, are within normal limits. So from my history and clinical examination, most probable clinical diagnosis is decompensated chronic liver disease. So now it's time for some explanation. First of all, the patient presented with two main history: generalized swelling for 3 months and yellowish coloration of eyes and urine for 15 days. So he had edema and he had jaundice. Those two are the presentations, edema and jaundice. Now we explained the generalized swelling, how it involved. First involved abdomen, then involved the lower limb. So whenever the edema first starts at abdomen, it goes in favor of a liver pathology. Then I have also mentioned about some negative history, abdominal pain and alteration of bowel habit. This is to exclude other cause of abdominal swelling such as abdominal TB or intra-abdominal malignancy. Chest pain, orthopnea and PND, we are trying to exclude left ventricular failure. Persistent cough, trying to exclude any lung cause such as cor pulmonale. Or high colored urine, we are trying to exclude renal cause such as glomerulonephritis. And then for yellow coloration, for jaundice, we mentioned that this is gradually progressive. Then we excluded that this is not obstructive by saying that it is associated with dark stool but not associated with pruritus. Dark stool but no pruritus. That goes against obstructive jaundice. If it was obstructive jaundice, the stool would be pale and there will be itching, and on examination you will find the itching marks or scratch marks. I've also mentioned the right upper abdominal pain, fever with chills and rigors, so we are excluding diseases such as lung abscess and cholangitis. And I've also mentioned no history of preceding prodromal illness. That means this is not viral hepatitis where you have the prodromal illness, or progressive pallor. This jaundice is not due to a hemolytic cause. So the three main types of jaundice: the obstructive jaundice, the hemolytic jaundice, and the hepatic jaundice. We are saying that yes, this is hepatic jaundice, but the patient does not have any obstructive component because there is no itching and the stool is dark, and there is no hemolysis because there is no progressive pallor. Then we have mentioned the treatment course, how he was treated. Initially he was admitted in MMC, gone through some investigations. Then he was referred to BSMMU, gone through some investigations, but developed another symptom, which is hematemesis. And we have mentioned the treatment of hematemesis, which is IV fluid, blood transfusion, and also endoscopic varicose ligation. Then we have mentioned what about the other complications of CLD. Up to now, we have presented the case in a way that it seems that the CLD is the logical cause of all the presentation. But what I'm saying now is I'm trying to exclude other complications of CLD, which are hepatic encephalopathy. And for hepatic encephalopathy, I'm mentioning that there is no alteration of sleep pattern or abnormal behavior, any seizure or unconsciousness. We are trying to exclude all this. And I have also mentioned high fever with abdominal pain. That is to exclude the spontaneous bacterial peritonitis or SBP. Okay. Then I have mentioned the risk factors for chronic liver disease, if there is any. We have mentioned about the viral hepatitis risk factors, mentioned about the autoimmune risk factors, and storage disease. So for viral hepatitis, I've mentioned that about previous jaundice, surgery, unsafe sexual exposure, blood transfusion, and sharing the razor. And he had one positive history, which is sharing the razor. And then we have gone through history of TB, because TB is a good differential in any case of ascites. Then the family history, children and families. Then personal history, smoker, non-alcoholic. And then we have gone through the general examination. In general examination, the most important points to be focused on is the jaundice, because this is the presentation of the patient. The patient has jaundice, the patient has anemia in the eyes, and if you go down, you have raised JVP, and then on the chest you have spiroangioma. And if you go to the nails, you have got leukonychia and also palmar erythema. And you have got IV cannula in situ. Then if you go down, you will get in the leg, you will get the beating edema. Important negatives include the absence of lymphadenopathy, because if there is lymphadenopathy, then you will think that yes, this probably is a case of disseminated TB, or it may be a case of lymphoma. So we are trying to exclude TB and lymphoma because there is no lymphadenopathy. Purpuric spot or bony tenderness, because whenever you have this kind of case, lymphoma is a good differential, and leukemia is a distant differential. So we are trying to exclude them. Then bedside urine for protein is negative, very important test. We are trying to exclude nephrotic syndrome. No flapping tremor, that means the patient currently is not in a very severe state or not in hepatic encephalopathy. Then on abdomen examination, we have mentioned the findings that are classic with ascites, which is distended, flanks are full, umbilicus central, transverse slit, and you can also say effurid. Engorged visible veins are seen, very important, and there is puncture mark. That means the patient's aspiration was done to probably relieve the ascites. Then ascites is present. Obviously, all of those are features of ascites. Then we have also found shifting dullness, so ascites is present. And another important point in examination is testis. Testis is small, soft, and non-tender. That means the patient has actually evidence of hypogonadism. And this is due to abnormal metabolism, and there is increased estrogen, and the ratio between testosterone and estrogen goes in favor of estrogen compared to the normal person. So that is my long case of chronic liver disease.